Fine. How you been?
Yeah, I've been well, and you?
Yeah, busy, getting now that things are rolling again.
Yeah. Obviously, private started up again, so that's good.
Private has at the end of I think at the end of this month, 100%.
Here we go. Hey everyone, welcome to Anaesthesia Coffee Break. I'm Lahiru.
And I'm Stan.
And today we have a very special guest, Mandy Barrett.
Yeah, look, I know Dr Mandy Barrett very, very well from the Northern Hospital where I was a trainee. She's a big inspiration, and she does a lot of work outside of medicine, which many people may not know of. And I know she probably doesn't want to tell me this, but she actually won the highest award in Mongolia recently, the Polar Star Award for all her works there. So she's an amazing soul. And I did go with her to Mongolia in 2014 to do some teaching there. And Mandy's an amazing educator. And I'm so happy that she's agreed to come on to talk to us about a really interesting but esoteric topic. But I think that's one that does get asked either in the Viva, and I don't think it's been asked in the written yet, but always a possibility. So Mandy, thank you so much for coming on and welcome.
Thanks for having me, and thanks for that kind introduction, Stan.
Let's talk about herbal medications. And I think that to start off with, Mandy, like how would you go about if you got asked about herbal medications and its relevance to anaesthesia?
That's a good question, Stan. So I think what most of us are aware of is that a large proportion of patients actually are using herbals for indications, and they often won't disclose that they're using them. And I think it's important to bear in mind that what you don't ask about, you will never find out about. That goes for both herbals and for illicit drugs, which is what we're going to talk about a little bit later on. And I think the most important thing is to work out what it is that people are taking, including over-the-counter and herbals. And some of the things to keep in mind are that herbals come in all shapes and forms, and I think that that's something that can be tricky for us, because you can take herbals as a tea or as a different formulation, sort of powders, that sort of stuff. So it's actually quite tricky. When you ask a patient, they don't see that as medication. And I think that's one of the most important things to realise when you're starting to think about what herbal medications are all about. And when we think about herbals, we sort of got to think about, well, what are some of their actions? And there will be some pharmacological actions. There'll be also be some pharmacokinetic interactions, and that will be important for when we're thinking about other medications that are commonly used. And many of these agents will act on the cytochrome P450 system.
So
it's actually. Yeah.
I've got to confess, I just don't take much of a herbal medication, alternate medication history. And maybe I could be being really silly right now, but I've always thought that except for the Gs that have some blood thinning effects in fish oil, a lot of them don't have such an impact on my anesthetic. But, I suspect I'm wrong here, and that's why we're having this chat.
Well, not entirely, actually, Lahiru, because I don't know that there's actually a lot of evidence that we need to be too worried about it. And sometimes we overstate things. There certainly are some drugs that will cause potentially liver failure. And so that's something that we need to keep in mind. But, aside from the fact that there's going to be hepatic toxicity, in terms of the anaesthetic, that's not usually a problem. But there are some, and so what we have at the moment is this kind of blanket rule. The ASA in America and the ANSCA have this rule that we should ask about the herbals and ask patients to stop them for 2 weeks is the kind of the blanket recommendation. And I think that what that tells us is that we're trying to apply the same rule to lots of different things, which, as we know, doesn't always work out. Particularly if you think about other medications, you wouldn't be asking a patient to stop them for 2 weeks, and it's not necessary often. And you'll get the odd patient that'll turn up and they haven't stopped it. And so what do you do there? Do you cancel their case? Well, I don't know that that's necessary. And I think you just need to know what it is that you might encounter with that medication and mitigate risk. And, you know, clearly if someone's got liver failure, that's going to be a problem. But if someone's got just a mild platelet inhibition, then you can usually work with that. Unless they're on other anticoagulants.
And that duration of 2 weeks is really interesting. Like often when you think of, when we stop drugs, we base it on either the half-life of the drug or its physiological actions on, you know, let's say platelets, which you stop it for 7 days. So where do you think the 2 weeks has come from?
I think that's come from a position of let's try and be safe with as many of these as we can. And sort of, as Lahira said, the G drugs we've got to worry about. So the ginseng, garlic, ginkgo, ginger, we've got to worry about the antiplatelet effects and potentially anticoagulant effects of those ones. And so they're important to know about. And I guess because it's platelets, we worry about the duration of action on platelets. And so I think that's where that's come from. But I don't, some of the others, of course, there hasn't been a lot of data on. So people will just say, we'll just stop it for 2 weeks and then it should be mostly cleared. So most of it will be metabolized by then. But, you know, we've got to work out why the patient's taking the medication. So what is it that they're trying to achieve with it? And there are some medications that you've got to worry about. Well, there might be some sort of withdrawal. So something like Vallerian, for instance, which is a little bit of a sedating agent. And, you know, that works in a similar way to benzos. So you've got to worry about whether or not they might get even a bit of a withdrawal if you do that. So if you know what it is and what they're on it for, then usually you can work out if it's necessary to stop, or if they haven't stopped, whether it's going to be important to you.
Amanda,
not great.
Do you have a list of, say, is there just a common set of medications that are the most important ones to consider? Like we went through the G's, fish oil, Vallerian. Is there another couple that are just commonly, I think St. John's Wort's a big liver enzyme inducing one. Is there any, does that kind of encompass most of the ones that we really need to care about?
Yeah, I think you're right there, Lahiru. I think there's only a few that we've got to worry about, but then, you know, there's always something on the horizon that people take, and the weird and wonderfuls that, you know, it'll be like just as it is with any new medication that you come across. You've got to look it up, don't you, and work out and see if there's any evidence for interactions. And so I think the main, there's probably about 9 or 10 that you've got to know a little bit about. And I wouldn't say that you need to know a whole lot about these things. If you look at the literature, a lot of the review articles on herbals and anaesthesia will give you a table of medications. And I must confess, it's very hard to remember the detail in the tables. And I think that for first parters, that's going to be a tricky thing to do. So I haven't had a good system for remembering stuff, except that I think it's important to prioritise the ones that you do need to know about. So St. John's Wort, I think, is really important to know about. So that's one that is commonly used, and it actually has got sort of pharmacological effect. And as with other herbals, there's usually more than one active ingredient. So St. John's Wort's got more than one active ingredient. And the effects of St. John's Wort are, of course, people use it for as an antidepressant, but also for anxiety and sort of symptoms of agitation, that sort of thing. And so it has some pharmacological effects, including serotonergic effects. Serotonergic effects. They'll inhibit the monoamine oxidase system, and it also induces cytochrome P450. So you can expect perioperatively what might happen is that you might have a serotonergic crisis if you've got interactions with other medications, particularly SSRIs, but there may also be a bit of a sedative effect. Plus, there'll be some problems with metabolism of other agents. And so you want to stop that, well, you want to know about it. And if you do know about it and find out about it early enough, particularly in the pre-admission clinic, you want to stop that for at least 5 days. But again, this blanket rule of 2 weeks usually is what we'll consider safe. So that's something to know about.
Do you have
go on.
Sorry, do you have a sense of how contraindicated it is? Like, say someone's on St. John's Wort, they haven't stopped it, and you wouldn't cancel elective operation, but would you then not use tramadol or a serotonergic active pain med? Yeah, I'm trying to gauge what the level of contraindication it might be, or it's not really known.
Well, again, it's all going to be dose dependent too. So like tramadol, St. John's Wort actually comes in different formulations and different doses. So you might want to know what dose the patient is on and have a sense of what's considered a high or at least a therapeutic dose, because there'll be patients that are on it that are just on a small amount, and that really won't make much difference. And if you'll already know that if you increase your dose of tramadol, that'll increase the amount of serotonin syndrome that you might see. So that would be where I would go with that. I don't think it's absolutely contraindicated to give tramadol in a small dose if you're going to use it for analgesia if there's nothing else that you've got. But we do have alternatives. And so, you might start with something else first. And then, obviously, if it's not working for you, you might consider if tramadol is, if you've got a good indication, you can use it, and then just monitor the patient for serotonergic symptoms. One of the things that you might see with St. John's Wort is actually drowsiness after your anaesthetic. So if you've got a patient who's taking a long time to emerge, you might want to consider that this might be the cause. And of course, there's no antidote. You just wait, don't you? It's like with anything, enough time and it will wear off, or your anaesthetic will wear off.
Get the CT scan and yeah.
Yeah. Or it could be, you could have a sort of a higher threshold. You could just wait a bit longer. Don't send them to CT straight away if you know that they're on St. John's Wort, particularly in emergency.
That's really good. So for all the trainees out there listening, if someone asks you a question and you got St. John's Wort's, just to summarize, it causes induction of the cytochrome P450, and so then you can think about different drugs which require the cytochrome P450 enzymes like warfarin.
Yeah.
And then it also inhibits neurotransmitter reuptake, which increases your serotonin levels. And then, as Mandy was saying, that's going to have interactions with tramadol. And then it causes sedation, which may affect your anesthetics. I think that's a really good list to have, and a really good sort of starting point for one of the most important herbal medications.
And one of the things I do want to just highlight is there have been some cases of cardiovascular collapse with it. So, again, you just treat things as they emerge. So you can't always predict some of these things. So you just got to treat it if it happens. So just be aware.
Cardiovascular collapse during anaesthesia attributed to St. John's Wort.
Yeah, and again, how do you separate that out? Like, I don't know, if you've seen one of my charts, you'll see that hypotension is quite common after induction. So,
and everyone's chart. No, yeah. That means you've done the appropriate anaesthetic dose, right?
But so the other thing is, of course, in elderly patients, although I don't know that that's very common, but you might get the odd patient who's elderly who's on this. They've got a bit of clouded sensorium or confusion. This might be part of the reason that they're getting it. So, you just need to be aware of that. One of the other things that for anaesthetists with St. John's Wort is that it does increase the metabolism of L-fentanyl and midazolam. So it can be unpredictable as to what effect you're going to have with your drugs.
That's a really good list for St. John's Wort's. Now I think Lahiru and yourself mentioned all the G herbal medications, and what list do you have for all the G herbal medications?
Well, I've got stuff, a large number of medications that will interact with platelets, but the most important ones are garlic, and lots of people take garlic. You'll be surprised. And it's supposed to be it's supposed to be used for treatment of hypertension, but I don't think it's that effective for hypertension. But certainly it has a HMG-CoA reductase inhibition, so it will lower cholesterol. So it's probably quite good for you if you've got cardiovascular disease. And it's used to treat atherosclerosis. And the antiplatelet effect, I imagine, would be quite useful if you've got cardiovascular risk factors. And so people will like to take garlic, but of course the antiplatelet effect will increase your risk of bleeding theoretically. And really that's probably, again, dose dependent. And there are a number of patients that take really large amounts of garlic, but I don't think there are that many. A lot of patients will take a mixture of stuff. And so they might take a garlic tablet and something else, but often the dose of garlic's not that high in some of them. So just be aware of the formulation. Again, a bit like St. John's Wort, work out what dose it is that they're taking, and then you can work out whether or not you need to worry about it. So garlic's the first one. And of course its antiplatelet effect can be significant. The other one I always think about is ginseng. Ginseng, it comes, there's a kind of an American one, and there's I think there must be an Asian one, and then another, I can't remember where else it's grown. There's like 3 types of ginseng around the world. So we kind of lump them all together, but they're not all the same. So it's supposed to have a mild sympathomimetic effect. But it's used to treat diabetes, and it's a weight loss medication, and it also improves well-being. So there might be some, and one of the papers that I read said it was a mild aphrodisiac. So you might see some patients on ginseng for those reasons. And again, this is one that might cause an antiplatelet effect, but one of its probably important effects other than antiplatelet effects for anaesthetics is it may cause hypoglycemia as well if it's used with other agents, so oral hypoglycemic. So be aware of that. And so again, if you've got a patient that's not waking up, you might want to check their glucose. But like I said, if they hadn't stopped the ginseng for 2 weeks, I don't think I'd be too worried about it. The minimum time to stop it is supposed to be 7 days, but I wouldn't be too worried about it. It can actually cause some cardiovascular effects like tachycardia and hypertension as well. So that's the other thing to know about, because it's of its sympathomimetic effect. But that's mild, so it's not usually a big problem with ginseng. Okay, so might make you feel great, make you more attractive, and so it also improves your mood a little bit. But it'll make you look slim and drop your sugar. So that's why people like to use ginseng.
I'm wondering, we should all be on ginseng. Sounds like the miracle drug.
The only problem for you, Lahiru, is that it might cause gynecomastia.
Oh, don't want that.
No.
Yeah.
No, don't listen to Mandy. Look, I grew up with ginseng and garlic when I was growing up in Malaysia. That's the secret to good cardiovascular health. That's why we're all walking around in our hundreds, still running around in the around because of all the garlic and ginseng that we eat.
I think you're talking about Okinawan Japanese.
And the other 2 Gs are ginger and ginkgo. So ginger is used quite a lot, and you might see some pregnant women on ginger because it's got an anti-nausea effect. So patients like to take it for that reason, but it's also a little bit anti-inflammatory. But ginger has got a number of effects as well, including the antiplatelet effect, and inhibits serotonergic pathways and stimulates the GI tract, which presumably is how it stopped you from feeling too sick. So that's another one. Again, you need to stop it probably 2 weeks before surgery for ginger. So that's the other G one that we need to think about. I don't know about you guys, but I use a lot of ginger in cooking, so maybe I
was about to say, I mean, I use so much ginger and garlic. I think I use all the non-ginseng, non-ginkgo herbs in my cooking that Maybe my blood's extra thin. Oh, that's
See,
worrying.
that's why you look eternally young, both of you.
Always
Yeah.
because
Well, thanks. That's very kind, Stan.
I bruise easy.
Yeah. So ginger is an inhibitor of thromboxane synthetase. So that's how it works for the antiplatelet effect. So,
I've got to confess that I'm pretty sure in the latest SAMBA guidelines, or even the ones previously, they said that ginger has minimal effect, if any. So they were saying, yeah, all the normal drugs, acupressure P6, I think it is, but not ginger.
Yeah, it doesn't help with the nausea.
Yeah. Or maybe that's post-operative nausea and vomiting.
Yeah. But lots of patients will try it for particularly pregnant women who've got illnesses.
Yeah.
So that's the ginger one. I don't know about you. It makes me feel better. And the last one in that group of medications will be the Ginkgo. Lots of people like Ginkgo because it's supposed to help you with your memory. Maybe I should be on that. And it's supposed to be neuroprotective. It's got free radical scavenging effects and some antiplatelet effects as well. So again, but its duration of action is probably a bit less, so it doesn't need to be stopped for 2 weeks. Probably 36 hours is enough for that one.
Okay. And do you know if there's any good evidence about the memory? I mean, this is the ability to memorize for our exams is going to be it's a massive takeaway that could be utilized. Is there much good evidence for the memory retaining effects?
There's not much good evidence for any of this, really.
Okay.
And I think that's the problem. But you can try it if you like. The only problem is that it may actually reduce the seizure threshold in children. So that's something to be aware of.
Okay.
So
right now, stick to the memory palace, stick to learning tables, and
yeah, I think that's probably better.
It sounds good.
And repetition is the secret to learning, isn't it?
Yep.
And Ginkgo.
Oh, yeah. The other thing that you might see it used for is intermittent claudication. So there'll be some patients who've reported improvement in their claudication symptoms if they use Ginkgo. Okay. So
great.
They're the G drugs. Go on.
The other blood thinning one, then fish oil.
Fish oil. Yeah. Again, I don't know that there's how effective it is at thinning your blood, but so if you know about these drugs, I think it's fine. But if you believe that there is going to be a bleeding problem because of either the patient or other medications the patient's on, then sure, you need to consider that. But, how does this affect my practice? Not very much is the honest answer.
Yeah. So note for your part one for essentially, knowing these things and knowing that they can have certain effects, maybe. And we don't have too much evidence, just have an index of suspicion in the back of your brain, but really we're not making too many calls about cancellations and postponements based on this. It's all
I wouldn't be cancelling a patient unless you think they're on high doses of warfarin, aspirin, and something else. And
a haemophiliac with fish oil, not great.
Yeah, probably not. Well, I don't know. Fish oil, I haven't seen much evidence for here, so I don't know how effective it is in making you bleed.
Okay.
But yeah. So certainly something to think about. And I guess it'll be dose dependent. So those are the G ones. And the one I do think that people need to know about is ephedra, which I think has been banned in Australia, but it has been used in Asia a bit. And that's because it's like ephedrine.
So when that patient's saggy after operation, instead of IM ephedrine, just give them a root of ephedra.
Yeah, I'm not quite sure how it comes, but yes, you're quite right. So ephedra is probably one to know about, and because that's certainly, I think the other name is Ma Huang. So patients might be on it if they brought it from overseas. So that would be, and again, that would be important because that's going to be an indirect sympathomimetic. So you're going to you will have all of the effects of the sympathomimetics.
And so that really is for staying awake, like a stimulant, like caffeine?
Yeah, so and that's what people tend to use it for weight loss, and as a stimulant, a CNS stimulant. And you need to be cautious with other sympathomimetics when patients on this. But again, it's not a long-acting agent, just like ephedrine's not. So if they've stopped at 24 hours before, that'll be okay.
Oh, interesting. I've actually, I feel like I remember ephedrine in the recess of my brain, but I don't think I've even noticed it in the pharmacies or any health food stores at all.
I don't think it's available in Australia so much, but
Okay.
yeah, I suspect it's been banned. And so those are the main ones. The other ones to know about, so we've done the Gs, we've done the ephedrine, the St. John's wort, and the other ones to know about are Kava and Vallerian, which are the sedative type ones.
Interesting. I've actually tried Kava back in the day when I was elective in Vanuatu.
Yeah, how was that?
Yeah, really unpleasant. It's like so you drink it and it tastes like muddy water, and then it makes your mouth like a bit numb, so it's got that local anesthetic effect, and then it does make you feel like sedated, but it's almost like having a little bit of the enjoyment of alcohol, but then having a hangover kind of feeling straight away.
Yeah.
And interestingly, because your mouth is numb, when you're drinking it, you just like the locals have this need to kind of spit. So when you go to the Kava bars, the floor is just covered in saliva. So it's just a different environment.
Yeah. So there are quite a lot of active ingredients in Kava. So it's not just one. So it's probably why it's got all of those effects. And yeah, it probably is an acquired taste. So as far as we anaesthetists are concerned, you might have a potentiation of benzos and induction agents if someone's acutely intoxicated with Kava. The other thing is that you need to worry about hepatotoxicity with this one. So there are some reports of hepatotoxicity with Kava, and so that patients who are on it chronically probably need to be monitored for that.
I wonder if in the islands where most Kava is drunk, I guess, I wonder if there is an increased rate of liver disease. Actually, I do remember there's 2 medical problems I saw in Vanuatu. One person had so much Kava they had Kava skin, so had this really odd kind of skin condition based on Kava. And the other thing was just the accidents that occur. Someone fell asleep, pushed over the kerosene lamp, had really significant burns from that. So just the effects of being sleepy and drowsy around that situation.
Yeah, I think those are the main problems with Kava. And of course, the Vallerian we've spoken about before. So again, that potentiates the GABAergic system. And it's a anxiolytic as well and a hypnotic. But also a bit like diazepam, you've got to watch out for patients who are chronically on this stuff and check out to see if they might have some withdrawal if they're dependent on it. So those are the main things to know about those 2 agents. And the final one I think that the trainees probably should be looking at is Echinacea. Yeah, so Echinacea is probably something we'll see a little bit of because there are lots of people out there wanting to boost their immune system.
Hold on, what do you mean? What?
Yeah, well, there's a pandemic. So
what pandemic?
What pandemic? So Echinacea is a medication or a herbal medication that some people will be taking, particularly for coughs and colds, or chronically sometimes to prevent a cough or a cold. I certainly know a lot of people out there who use it for that purpose, and it's mostly upper respiratory stuff that they're trying to avoid. It actually does modulate cytokines and it stimulates macrophages and natural killer cells. So the problems with Echinacea are that it's, it tastes unpleasant is the first thing. So patients that's fine. I'm not taking it, so they can have it. But there has been reports of anaphylaxis to it, even with a single dose. Not that that's really going to be a problem for us, because we may encounter them in ED, but we certainly won't be thinking about giving echinacea for the first time with an anaesthetic. So that has been reported. It can be hepatotoxic. So this is another one where you've got to worry about it. And some people will have an increased response to midazolam if they're on echinacea as well. So they might be a bit more drowsy if you're giving midazolam. One of the other things is that its effects on the immune system are that it will reduce, it will increase your immune response initially, but then it will reduce your immune response chronically if you take it for too long. So that's the problem with it. So patients that need immunosuppression will actually be harmed by the use of echinacea. So if they're on transplant, if they're going to be considered for a transplant, you probably should avoid it.
Right.
Yeah, because it'll interfere with the immunosuppression that you need.
And so if you had a patient on echinacea, it's more so just to for them to stop it if they were consideration of a transplant, not if they had like hepatic disease or renal disease. Is that right?
Well, it's a hepatotoxic agent, so probably it's not a great idea if you've got hepatic disease to be on it. So it will impair your liver function. But I don't think it's otherwise healthy patient. I don't think it's going to be a great problem if you're. But if you're on it chronically, you may, how I said, it stimulates your immune system initially for the first few weeks or months, and then potentially it will be you'll have immunosuppression later on. So this is kind of, I think if you've got someone on it, you've got to think about seriously advising them to stop this one. Yeah, and the minimum time would be 2 weeks for this one.
Yeah, it's really interesting. And I'm trying to think, like, so in, the fact that I don't take a history specifically for alternate medicines, probably not the worst thing, but yeah, maybe in very specific circumstances like immunocompromised patients or transplants that, do you reckon surgeons are searching for this history? Because I know some surgeons always ask about fish oil and the Gs. But in the anesthetic context, again, probably not as necessary because there's no contraindication with regional anesthesia or significant enough bleeding risk that things are going to go really badly. Yeah, it's interesting.
Yeah, correct. So, I mean, it's not going to be usually a huge problem for us. It's going to be a problem for the surgeons mostly. And, I guess, I don't know that there's a lot of evidence, but I'm certainly surgical people will know about it. If there's trouble with your immunosuppressants.
Yeah, excellent.
So for not much, Mandy, there's actually quite a bit there, isn't there? Like, so you've got the St. John Wort, you've got the garlic, ginger, Ginkgo, Ginseng, and then you've got the sedatives, Kava and Vallerian, and then you've got ephedra, and then you've also got Echinacea. That's a great list, and I think that's enough.
Yeah, that's plenty. It's plenty to know about.
Plenty to discuss.
And I guess the message really is take a history of, or ask the patient what else they could be on, and bear in mind that some of these products have more than one active ingredient in them. And then if you don't know about it, or if you've never heard of it, there's always Google. Look it up before you start anaesthetising them. And if you do have a problem, particularly with emergence, have a think about whether or not this could be due to a herbal medication that perhaps you haven't asked about.
Hey, so that's pretty much a wrap of the information, I imagine.
Yeah, that's more than enough.
No, excellent. No, that's great. Thanks very much, Amanda. That was so useful. Such a great insight into all those different medications. So that's it from Anaesthesia Coffee Break. Thanks so much. And next time we're actually going to get Amanda on to talk about illicit drugs. And these actually have a, very, very potent, very efficacious pharmacological effects that can really affect anesthesia. So that'll be a really interesting episode. So yeah, make sure you subscribe to us so that you don't miss that. So thanks very much, and we'll see you again next time. Please share with anyone who might be interested. See you again. Bye.